How's it going, guys? We have a medium difficulty question for cardioendocrine steps 1 and 2. 68-year-old man. Congestive heart failure managed with enalapril, metoprolol, spironolactone, furosemide, hydralazine, isosorbide dinitrate. Type 2 diabetes mellitus managed with metformin. Laboratory studies, sodium low 130 should be 135 to 145, potassium normal 4 should be 3.5 to 5, bicarbonate normal 24 should be 22 to 28, calcium normal 9 should be 8.4 to 10.2, BUN upper end of normal at 20 should be anything 20 or lower, and then creatinine, which we don't list, should be 0.7 to 1.2. What's the most likely explanation for these findings? Choice A, adverse effect of metformin. Wrong fucking answer. High yield for USMLE, that you know metformin causes lactic acidosis. So if we gave you this question here and then the bicarbonate, let's say, is 18, we said normal range is 22 to 28, that would presumably just be lactic acidosis secondary to metformin. You need to know that on USMLE, if the creatinine is 1.5 or greater, you want to discontinue metformin because of risk of lactic acidosis. Wrong fucking answer. Choice B, baroreceptor mediated vasopressin / ADH release. Correct answer. Now this question shows up on one of the family medicine forms, and it sounds very step 1-esque, baroreceptor mediated ADH release. They want you to know for USMLE, steps 1 and 2, okay, that the mechanism of hyponatremia that is sometimes seen in congestive heart failure is baroreceptor mediated ADH release. So the carotid sinus baroreceptors, not only do they sense stretch in terms of helping to regulate heart rate, it's a long discussion, okay? If you have more stretch, let's say increased blood pressure, you're going to get increased cranial nerve 9 glossopharyngeal firing afferent to the solitary nucleus of the medulla, increased vagal efferent firing down to the nodal tissue, and that's going to slow your heart rate, okay? And it's the opposite if you have lower blood pressure with decreased stretch. Well, if your heart isn't pumping the way it's supposed to, if your systolic impulse is attenuated, your carotid sinus baroreceptors think that your blood volume is lower than it should be. It's not receiving that systolic impulse at the strength it's supposed to if your heart's not pumping. So therefore, it's going to increase free water reabsorption to compensate. Okay, it's one of the roles of the baroreceptors is that if you have reduced stretch, ADH goes up in an attempt to increase free water reabsorption. And likewise, if you had increased stretch, then theoretically ADH could go down. So I've talked about in my cardio PDF, which of course I've linked below. So your carotid sinus baroreceptors, not only the autoregulation with heart rate, with cranial nerves 9 and 10 as I already discussed, but also ADH. Okay, so there's increased ADH in the setting of systolic dysfunction, and they ask it just like this on one of the NBME questions. Let's just whip through the final ones real quick, tell you some highlight points. Cellular shift, wrong fucking answer. That's the mechanism for hyperkalemia in the setting of DKA, which is type 1. You don't get that with type 2 diabetes mellitus. It's a long discussion, everything here. Do a 40-minute seminar and all these side points. But when you have DKA and you have absent insulin, you can't push the potassium into cells the way you're supposed to. So that's one mechanism for hyperkalemia. And then the second is as you make keto acids, protons increase. The cells are going to buffer those protons, increase positive charge in the cell, and some of that potassium inside the cell gets kicked out to compensate. So if they give you hyperkalemia in the setting of DKA, you got to know deficient insulin, as I talked about, can't push potassium in cells. And also cellular shift can just be written as an answer. Choice C, wrong fucking answer. Choice D, prerenal azotemia, wrong fucking answer. It's not even renal insufficiency here, albeit you should know that diuretic use, congestive heart failure, they are high-yield etiologies for reduced glomerular filtration, reduced renal perfusion. NSAIDs, diuretics, chronic congestive heart failure, dehydration, vomiting, diarrhea over several days classically, BU endocrinine ratio greater than 20, fractional excretion of sodium under 1%. Choice D, wrong fucking answer. Choice Z, psychogenic polydipsia, wrong fucking answer. It would cause low sodium, and it would also cause dilute urine, but we overwhelmingly have a vasculopath here. Okay, you can't read between the lines and overthink dumb shit. on USMLE. We clearly have a better answer. It's a very buzzy answer. Now that you've learned it, it's not hard. You say, oh, I've seen that before, okay? So they can just tell you patient's drinking too much water. That's what psychogenic polydipsia means. But you have dilute urine and you have low serum sodium. Wrong fucking answer. You know the deal. When you make more content, I'm going to subscribe to you. Appreciate your time. That's it.